Today I gave a talk on the changing landscape of pharmacotherapy for diabetes and emphasized just a few aspects of that. One is, I think decreasing emphasis on metformin, an old friend, first-line drug for diabetes, in favor of medicines now that have been shown to give us not only better glycemic control, but also to treat risk for cardiovascular disease, to prevent cardiovascular disease events, to prevent renal decline, and to prevent congestive heart failure outcomes like hospitalization and the need for acute intervention. So we're going beyond glycemic control now to treating specifically these very dangerous complications of diabetes as well. And I'm talking about two classes of drugs in particular. One is the SGLT2 inhibitors, which have been shown to be renal protectives and to prevent congestive heart failure outcomes in diabetes, and GLP-1 receptor agonists that have been shown to also be renal protective and also to prevent cardiovascular disease outcomes. So, and this is reflected in multiple guidelines by the American Association of Clinical Endocrinologists, the American Diabetes Association, et cetera. Really think about beginning with SGLT2 inhibitors or GLP-1 receptor agonists if your patient has established kidney disease or at high risk of cardiovascular disease or has cardiovascular disease or a risk of congestive heart failure. Metformin can be used and other drugs for glycemic control if needed, but use these other drugs really independent of for glycemic control because we need them for these other health benefits. And then I think the other thing to emphasize is diabetes doesn't exist by itself. It exists within the greater nexus of this entity we call cardiometabolic disease, okay? Which is one pathophysiological process that gives rise to both metabolic and vascular outcomes. So anybody with diabetes is at risk of cardiovascular disease and congestive heart failure, like we talked about. They're at risk of MASH, metabolic dysfunction-associated steatohepatitis, or MASH, and hypertension and stroke. And then some of these conspire to impair kidney function, so you get progressive chronic kidney disease. So once in that patient with diabetes, we have to keep all of those things in mind and use medications and really engage in aggressive risk factor management because we know they're at risk of all those end-stage outcomes if they don't have them already. So kind of a little bit about the changing landscape and the way we think about treating diabetes beyond just glycemic control.